Okay, so I'm going to talk about aneurysm coiling techniques, and I borrowed a few videos from Dr. Monteith to show you at the end about, the different techniques of coiling aneurysms. I think that I wanted to give you a system to do this. You've played around with the tools this afternoon to try to figure out how comfortable you are with the equipment, but I want to give you kind of a system and think about this in terms of processes and how you prepare to do an endovascular coiling procedure. So you got to think about how to set up in your own mind what you need to have ready for you in the angiography suite. And a couple of things that people forget are some of the things that will help you with thrombotic complications. And I think that having antithrombotic medications available in a pharmacy that's very close by or within the actual neuro IR unit are very helpful. We heparinize for patients often, especially in cases of elective aneurysm coiling or treatment, and typically 70 to 100 units per kilogram off the bat. Antiplatelet agents should always be available. My personal philosophy about using those preoperatively is that all patients undergoing elective procedures should be pre-treated with aspirin Plavix, just in case you need to put a stent or you have to salvage a bad situation. And that goes for most aneurysms that are thought to be simple coiling procedures anyway. A couple of options other than Plavix. I think you heard Dr. Deschmok say that he uses ticagrelor off the bat because it's almost a more straightforward bioavailability. The issue with ticagrelor is that it's got a very short half-life, and so you have to make sure that the patient is on it consistently. And the two medications that have come in vogue over the last 10 years are RioPro or Biximab and Integralin or Ifetimide. I don't know how to say that. So the dosages are here, which I think are cardiac doses that you use usually in very difficult cardiovascular procedures, and we typically use the same for neurovascular. There's no research on the dosing for neurovascular, and so having an anesthesiologist have RioPro or Integralin ready, having them have the appropriate bolus dosing ready and infusion ready is appropriate when you have thrombotic complications. Obviously, antidotes, there's not many for RioPro or Integralin other than platelets, and antidotes for heparin include having protamine ready. Again, the conversion is pretty obvious there. The other thing you want to prepare for, other than the equipment, is your mental preparation. The keep it simple, stupid idea, I think I've learned that from Dr. Monteith, and I continue doing that now. I kind of highlighted in one of my other lectures that I try not to make it a really complicated endovascular procedure, and if it requires a very complicated approach, then I prefer just to do an operation. And there's always a plan in your mind, mentally, the steps that you want to take. Just like any other operation, just go through the steps in your mind before even touching or picking up a catheter. Most of the best surgeons that probably sit around at home or just before the procedure that they're about to do, thinking about how they're going to get through the steps and thinking about all the complications and roadblocks that might occur. So when you think about endovascular procedures, always think about the roadblocks that might come your way, because when those roadblocks do come your way, when you're doing the procedure, it's not a complete panic, freak-out situation in the IR suite. You are the captain of the ship in the IR suite, and so if the captain panics, guess what? Everyone else is going to panic. The use of 3D angiography has revolutionized how to make those decisions of how to treat aneurysms, but also can help understanding whether or not the coil mass or devices that you're going to use are going to be appropriate in the positioning, and really taking your time to look at the 3D models, making sure the neck's appropriate, making sure the vessels that come out of the side of the aneurysm are the right orientation or configuration for stenting is very important. And understanding what equipment that you have on the shelf is very important too. Just like you know what kind of clips that you may have in your hospital and what kind of instruments that you may have in the operating room, you want to make sure that everyone knows these are the type of coils I have, these are the type of catheters I have, these are the type of balloons I have, these are the options that I have in case of a bad problem. Because when bad things do happen in the angio suite, time is of the essence, and unlike open surgery, because of the time is the essence, you don't have much time to play around with and think of interesting solutions. You have to have the solutions available to you immediately. Just going through some access techniques. There are many different types of access techniques out there. In general, it's always good to use a supporting catheter, a guide catheter that has enough support, and then beyond that, the use of a distal access catheter to gain further support. There was a time where we didn't have appropriate distal access catheters, and it would be very difficult to find the appropriate support for microcatheters in the head at their length. The microcatheters themselves come in various shapes and sizes too, and you can also steam certain types of catheter. It's sometimes easier to use a shaped catheter because of the configuration and how it may fall in an aneurysm, or the difficulty of getting access to distal parts of the circulation. There's many microwires out there. People have different preferences of the microwire. Each microwire has the characteristics of pushability, steerability, torqueability. These all are different from each different catheter. I prefer to use an Aristotle. People have used Synchro too. I was trained to use an Expedium, and there are other ones like the Asahi wire and the Transcend wire. Those are the 5 or 6 most common types of microwire that are out there for aneurysm treatment. Each of them has their own characteristics, I mentioned, and each of them has their own ability to navigate. With use and time and experience, you'll figure out which one is the most appropriate for you. I think for most beginners, though, the Synchro 2 wire has the most deformability or softness. So as a wire to use in terms of just ease of use, I used to call it the weekend wire because you can kind of like hang out and not do much with it. And as you get more advanced dealing with other types of pathology, including stroke, you can change the microcatheter use, or microwire use, sorry. Other things to consider is how to consider the other parts of the circulation and use them. We talked about how important anatomy is when you look at these aneurysms. So sometimes it's tempting just to look at the aneurysm and just focus on where it is and what the blood vessels coming out of it is, but you have to look at the whole circulation sometimes to figure out what is actually going on with this patient's brain, because that can give you either a clue to about how this aneurysm developed, interesting things about the aneurysm itself in terms of what can be sacrificed and what cannot be sacrificed. Using transcirculation approaches, I think we saw a case yesterday where someone came in from one side of the internal carotid artery, across the posterior communion artery to put a stent in a P1 to SCA fashion or P1 to P1 fashion. That seems to be a very elegant way to treat posterior circulation aneurysms. And the other we talked about a little bit today in one of the cases is to have bifemoral access or biradial access to access both vertebral arteries so that you can cross your microcatheters to get to a certain pathology. So with one microcatheter access the aneurysm, the other microcatheter place a stent, or the tortuosity of one vertebral artery makes it easier just to do a contralateral approach. I do want to talk a little bit about access because, again, it's overlooked. It's easy in the lab just to overlook that kind of thing. But the vast majority of places in the United States currently still do femoral access. But it probably is about a decade old and behind the cardiologists. Most of the cardiological procedures are now done through cardiovascular procedures done through radial approaches, and I think there's a national trend to do more radial procedures in endovascular. I do 90% or 80% to 90% of my cases radial now. Doesn't matter if it's a stroke, coiling, a pipeline. And so there are limitations, obviously, with the radial artery approaches, but just like the femoral artery approaches, it's just another tool in your armamentarium. I had to make it less boring. I borrowed this from Dr. Monteith. I don't know why he has pictures of Tom Cruise on there, but the radial access is important. I know. There's a theory that Tom Cruise has hollow prosencephaly because he only has one middle tooth. I'm not sure if that's an urban myth or a legend, but anyway. So when you're doing radial artery access, it's a little bit different from femoral artery. You have to prepare the artery, and you have to use a certain number cocktails or medications to make sure that the artery stays open throughout the case. Remember, the radial artery is actually a very small artery, and if you trash it on your way through, it can be a huge problem. So typically, you can use many types of drugs, but most cardiologists use verapamil, nitroglycerin, and heparin, or a combination of those, and I've started using that too. I've switched away from using nitroglycerin unless there's spasm, and heparin obviously used for every procedure to heparinize your patient, and I typically just use verapamil. And verapamil widens the blood vessels so that you can get bigger catheters into the radial artery. The radial artery it's like I said, a very small artery, and it's very important to do an Allans test. You can do the official Allans test before the procedure with the O2 sat monitor on the hand, or I like to do a radiographic Allans test where once your sheath or needle is in, you do an angiogram of the forearm, and you prove to yourself that there's an ulnar artery that provides adequate supply to the arcade and the wrist. And once you're satisfied with that, you know that you can get bigger catheters, you can widen the radial artery, you can even damage the radial artery without having too much of a problem with losing the limb. The biggest thing is, people are terrified about losing the limb. The risk of that is very low, but it can happen. The other thing that's important, like I said, think of a process in your mind, ultrasound guidance, and using a micropuncture set to gain access. I typically use a 7 French sheath that is a sheath that starts as a 6 French but can be expanded to a 7 French. You can use many types of select catheters out there. An internal mammary catheter or IM catheter or a SIM catheter seem to be the most common types of shapes. You can use any type of guide catheter. I typically use a 7 French guide catheter, but you can use a Neuromax or a Ballast or any other of the larger catheters if you don't plan on using a sheath. And obviously, when you take this whole system out, the nice thing about radial arteries, all you need to do is hold pressure, or have a device that holds pressure for you, like a device that across the wrist that supplies with a balloon. Or in the case of diagnostic procedures, just ask the patient to hold their hand up like this, and they'll control the bleeding right away. A little bit about the Coil Technology, jumping forward. I think it's important to understand how to understand and read a coiling box. So every coil has 2 numbers. The first number is the secondary diameter, basically the diameter of how this coil will shape itself. The second number is the length, which represents roughly, but not really physiologically, or physically, the volume that is going to be placed into the aneurysm. So 2 numbers, 2 by 6, 2 meaning the millimeter number is that secondary coil loop that the wire will make in the aneurysm, and the second number, the length of that would be in centimeters. Typical coils come in 10 and 18 fashions, and that's the wire diameter, the inner simplest part of the helical shape of the wire. Most wires are made of, most coils are made of platinum, and they come in 2 really broad stroke shapes. One is helical, the other one is random, which is just multiple degrees of freedom. Every company has a different principle on how they make those degrees of freedom based on the mandrels that they use to create the devices. And I encourage you guys, if you ever have an opportunity to go see the factories or the places where these coils are made, and you kind of get an understanding of how difficult it is to make a coil and how different each coil is in terms of which companies use different things. Again, thinking about how to coil, this is just what people use in the literature. There's a framing concept, a filling concept, and a finishing concept. What is interesting is that as you start to frame, you want to start getting from very stiff coils to much more softer coils, and there's going to be that apogee in the middle of your coiling where you just are trying to fill the coil as much as possible. Most people think of Russian doll technique, and basically that suggests that you're basically trying to get a large frame and you get smaller coils until you get the smallest coils inside the aneurysm. Eventually you get to the finishing coils, which should be your softest coils and should be your shortest coils as well. Most companies come up with these micro coils, nano coils, extra small coils. You've heard of all the names before. But the concept is you get a frame and you have to be happy with that frame. Again, I mentioned the first couple of slides that having a 3D before the procedure is very important, because that 3D helps you get that frame. Once you have that frame, it actually does act like a scaffold or an architecture. It almost is easy after that to coil an aneurysm, because once you have a frame, whether it's you use 1 or 2 or 3 coils for that frame, you know that every subsequent coil has has to stay within that frame because your softness is increasing. And so it's very hard for coils that are softer to extrude from a stiffer frame. So in most coiling procedures, once you have that frame, or the basket, it's very easy to then add additional coils and continue filling the aneurysm. The hardest coils are typically, everyone says, is that first framing coil to make sure it's perfect, and the last couple of coils and the finishing coils. It's difficult for the finishing coils because you really want to coil perfectly. And sometimes it's very hard to make sure that you get 100% packing density, or I should say, or approaching 100% packing density, although that seems to be kind of a metaphorical thing, just to make sure that you're treating the aneurysm adequately. Hydrocoils are their own entity in themselves, and the reason that is because they're completely different technology. The HEAT trial, which is going to be published in AANS, the White Journal soon, was a trial that was performed here in the U.S., looking at 600 patients. And basically, the bottom line of the trial is that there was a better rate of occlusion with these type of hydrogel coils. Hydrogel coils are coils that have a primary wind or a coil shape, and they're with the addition of a material that expands on interaction with water or aqueous solution. So they found that with the hydrogel coils, as they expand within the aneurysm, that these coils tend to have less likelihood of recanalization. However, there's no difference between using a hydrocoil and a normal coil when it comes to outcome in terms of like morbidity and mortality. So take it for what you will. Does that mean having a recanalization, is it that bad? I mean, who knows the answer to that question? All we know is that hydrogel coils tend to be more effective to fill your aneurysm. I think that's important when you choose your aneurysm, when you choose your coils, because when you are coiling an aneurysm and you're thinking about what coils are in your mind, you're like, this is going to be the last coil. I think this is going to be the last coil. If you switch to a hydrocoil, that just gives you a little bit more confidence that coil may expand to up to twice the size of its diameter and maybe the last coil. I want to talk a bit about adjunctive processes, and sorry, I apologize about the small writing here, but in addition, you've heard and probably seen a lot of talk about coiling procedures here today, and most of them have been straightforward coilings, but here and there you've had smatterings of discussion about using balloons and stent for coiling. There are very good reasons to use a balloon and very good reason to use a stent. I was trained to use a balloon to do most of my coilings, and where I came from, 99% of the aneurysms were treated by endovascular approaches. It didn't matter what they look like, and part of that success with endovascular treatment for every aneurysm that came through the door was the use of the balloon and being very versatile with that balloon technique. The balloon can be shaped and molded into most of the modern ones can be shaped and molded to accommodate any shape of neck of the aneurysm. There are many companies that make balloons now. The two most common balloon types are the Hyperform balloon and the Scepter XC balloon. The Hyperform is made by Medtronic. The Scepter XC is made by Microvention, and they are compliant balloons that essentially can mold around the aneurysm, as I mentioned. It's important to check your balloons and know how to prep your balloons. Each of these companies, I would encourage you to take a look at these packaging, and there's YouTube videos on how to prep these balloons as well. And they can be very useful to keep the aneurysm coil mass inside the aneurysm itself. Stents do kind of the same thing, but you're putting a permanent device in there, and that requires antiplatelet agents. And so to avoid antiplatelet agents, people have used balloons. 3 years ago when I was in at the International, the World Federation of something, Neurointerventional Society, something, someone came up with the whole concept of ballow stent or balloon stenting. You can actually put a stent through the Scepter XC. So the balloon catheter can actually deploy a stent through that. So let's say you're using a balloon, you're coiling the aneurysm, and you just realize that it's not quite working out quite right. You have the option to put a stent through the Scepter XC balloon and drop a stent after your balloon coiling, if you don't think it's appropriate. We'll talk about double catheters, and the other technique that I think you might have seen in some of the giant aneurysm cases is the over-the-dome technique, where your microcatheter actually has to crawl up and across the dome of the aneurysm to get to an outlet to get more purchase in the distal circulation. talk a little about the dual microcatheter technique. This is a technique that I think here in the U.S. was pioneered or kind of put into mainstream by Avery Evans at University of Virginia. And the concept is to use two catheters within the aneurysm dome. Sometimes one catheter is more proximal or more distal than the other one, and often the coils that you put through each aneurysm are different. So one could be a framing, one could be a soft coil, and it avoids the use of a balloon in cases where you're trying to struggle. You think that using a balloon is going to be a struggle, and just like the balloon technique does not require dual antiplatelet agents. Some tips to use some tips to think about when doing a dual technique is that you need to make sure very clearly when you're on the table which catheter is which when you're trying to coil, making sure that you're detaching one coil before deploying the other one. It's not a good idea to keep one coil in there while the coiling is going on and while you're putting multiple coils at one side. And I would probably stick to the same company type coils if you can. If you try to use two different types of companies, and I don't know how the coils would necessarily interact, if there's some kind of weird interaction between the different types of coils. Also, the shape of the coils is very important. You want to make sure the shapes are very similar as you coil through the aneurysm. The concept is that you're entangling these coils with each other. So as you put the coils through, let me show you a video of that. I'll take a break from this presentation to show you that. So this is a tiny, excuse me, this is a tiny pica aneurysm. And I think I remember doing this with Dr. Monteith a while back. And here are some more images of it. Oh, sorry. Lee? Someone? Anyone? Hey, need some help with this thing.
Trying to play video? Oh, this. I just gotta drag it over.
Oh, yeah, nice.
Oh, nope. Cancel that. Just make it bigger. There you go.
Shoot. Okay. All right. So I'll play this over again. I'm trying to, it's like weird. Where's my mouse?
This is on your screen still.
How do you get up to that screen? I don't know how to say it. Oh, there it is. Yep. Sweet. Okay. So yeah, here's a pica aneurysm. It's a proximal pica aneurysm. You've seen something very similar, and we've talked about this several times during this course today, and I'm surprised that this technique didn't actually come up in our discussion. But this aneurysm, is tiny, but you can see here, we're putting one microcatheter into the aneurysm right now. The microcatheter is, God damn it. The microcatheter is one microcatheter is already in there right now. Another microcatheter is going in over a microwire to follow the first catheter. You can see in the middle two top images, AP or two different projections of the same thing. So two microcatheters are going into this tiny little aneurysm, and now we're going to coil the aneurysm, I guess, and you'll see each catheter slowly, get coils into the aneurysm dome itself. I'll speed through this as soon as I can get the mouse to work again, but the key is obviously try to have the microcatheter tips in different positions if possible. Here, a little bit close, And the second thing is once you've picked the right appropriate type of coils, you want to make the coils pretty similar in 3D configuration, detaching one off the other. Oh my God. I don't know why. This is not playing. So just skipping forward here, just a little bit. In the video, we'll continue to coil these things. Continue to add coils through each of the microcatheters. And because of the entangling process, we're able to kind of treat the aneurysm without messing around with the actual pica vessel itself. And you can see that you can entangle the aneurysm and treat the dome pretty well. And once you're done, you can just pull the catheters out, and it looks pretty good in the case, as you can see there. Moving back towards the lecture. The other way that I'd mentioned was balloon-assisted coiling. It's very useful in subarachnoid hemorrhages. It's very useful in any type of procedure, but you don't have to use dual antiplatelet agents. You can treat aneurysms in different fashions. I tend to have a balloon ready in case I need to use it, but not necessarily inflate it off the bat, and try to coil the aneurysm. If there is a coil that seems to be migrating, or the frame seems to be migrating into the parent vessel, then you can inflate the balloon. Always test the balloon in a normal blood vessel as you go up to make sure that it inflates and deflates appropriately. Always only use the amount of volume that the balloon can occupy. So have syringes that only have the volume that will be in the maximal be the maximal volume of the balloon itself. If you have too much liquid in a syringe and you're injecting, you can make the balloon burst, and that can cause a problem, or overinflate. You can have problems with being able to see the balloon in the appropriate contrast, so you need to make sure that the contrast is appropriate for that. You need to make sure that the balloon is able to deflate appropriately. Sometimes, if you're lucky, you can actually have cadence syringes, which are syringes that click, as opposed to, for the balloon, as opposed to a normal syringe which has a plunger. You can have syringes called cadence syringes which click, and so you can actually appropriately monitor the amount of volume that you're providing or regulate the amount of volume that's going into the actual balloon itself. When you're in a normal blood vessel and you're inflating the balloon, remember, this is just like surgery. You're basically doing temporary occlusion, or using a temporary clip for occlusion. So you want to be timing this appropriately. Some people, at my old institution, for example, we used to use neuromonitoring for these cases. Now, neuromonitoring for these cases is not a bad thing necessarily, but if you have them on dual antiplatelets and you're heparinized out of the procedure, those needles will bleed at the end of the procedure. And I'm sure Dr. Monteith will as a test, when we used to do neuromonitoring for balloon procedures, when I was a resident, you'd be like making sure the patient needed a transfusion because they'd be leaking out of the scalp when the needles would come out. No one has ever found, there's been papers published, and no one's found any use for the neuromonitoring in terms of being able to tell you whether or not it makes a difference in primary outcomes. But some people use that to give them a sense of how long they can inflate the balloon or how long they can have the balloon. Also, make sure that the balloon is placed appropriately where you want it, because when the balloon does get inflated, it can move and further up and down the blood vessel. Again, I apologize for my technological incompetence, but I'll try to show you another case with a balloon here. So here, we're just testing the balloon before we go into the brain. This is just to make sure that you can actually see the balloon, that it's appropriate size and diameter. So in a normal segmental blood vessel, in this case, the high cervical / petrous carotid, you just test the balloon. This is a hyperformed balloon that deflates when you just pull the wire back out. In any event, we go further higher up over the balloon. You cross the neck of the aneurysm. You can see the aneurysm right there. And you cross it with a J. Here's the balloon. You can see the proximal and distal markers of it. It's going to straddle the neck of the aneurysm, and that's your one catheter there. We're going to place another microcatheter within the dome of the aneurysm. There it is. And then you can place coils in it, and when the coils don't go where you need to go, you can inflate the balloon, or you can inflate the balloon up front and make sure that the initial frame is appropriate. So here we are doing the primary coiling, and it's sped up a little bit, but the balloon's being inflated to the appropriate or nominal size. The balloon may move. It's hyper-compliant, so it can take the shape of what you need it to take, and then your coils go in. So your coil, this is the primary framing coil. The balloons stay where they need to stay, and the coils stay where they want to stay. And again, you have probably several minutes before you get true ischemic changes, but you obviously don't want to keep the balloon inflated through the entire procedure unless you're doing a rapid coiling. Again, you can take a little bit of your time to make sure that the coiling in the frame is appropriate and make sure it doesn't get the apparent vessel. Before you detach the coil, you deflate the balloon so that the coil, so you know the coil will stay in place. So it's important to do that. If you detach the coils and then you take the balloon down, these coils can go anywhere. So here we are, continue to coil the aneurysm with the balloon up. The subtracted angiogram in the middle is why you can't see the balloon. I think you get the point. So. Lee, I'm not sure this froze again. I'm not sure why it froze.
This video. Oh yeah. It's just gonna. There you go.
Sweet. Okay. Thanks. So the next thing I want to talk about is the use of stent. And stent is very similar to balloon use, and deploying a stent is very similar. Obviously, the major difference is physiological and adding dual antiplatelet agents before. It's okay to do a number of techniques. One of the techniques is to put the stent up and then penetrate the stent with a catheter to access the aneurysm. The other option is to jail the stent within the aneurysm. I will say, currently, if I'm using radial techniques, there's no good radial way to jail and stent a catheter in a stent, so you have to use individual catheters. So transradial, what I'll do is drop a stent and then traverse the stent to coil the aneurysm. If you're doing transfemoral, you can have two catheters in your distal guide catheter, and that will allow you to jail the stent if necessary. Certainly in cases where you're doing a pipeline stenting, or the case that we spoke about today where you're trying to put a few coils behind a big aneurysm with a pipeline use, you can do that technique and have a couple of coils within that and jail that technique. There's different types of stents out there, and each stent has its own porosity, and so you can decide on your own which stent is appropriate for you and your usage. And I also have a video of that. each stent has, like I said, different types of porosity, and you can use multiple stents to use it for flow diversion, although I wouldn't recommend relying on multiple stents to flow diversion unless you're changing the pattern of flow with your stent. Stents are stiff, and they can change the way the blood vessel is going once you've deployed the stent. Y stenting is basically a fancy word to say that you put the stent on either branch vessel, and T stents are stents that, as we spoke about early in the lecture, where you can go transcirculation and put a stent across a P1 segment or a P1 SCA segment, and it essentially looks like a T. You played around with a bunch of other newer novel T devices, one being the Pulse Rider device, I think it was at one station that I saw, and that acts like a T or a Y as in one device. Again, I hope that this video works. So here's a giant basilar apex aneurysm, and you can imagine coming across this. Half the battle is trying to figure out what the hell to do. The other half of the battle is to make sure that you treat it adequately. This is an over-the-dome technique where that microcatheter is going over the dome, and you can, or the wire is going over the dome and getting access to one of the P1 segments. It's not ideal to do this every time, but sometimes it's the only way to get distal access. And here we're working on doing that. So hopefully, if I speed this up, we're getting to that point. Once we gain access, you can deploy, here is an Elvis stent that Microvention makes. You're deploying the stent across the neck of the aneurysm. This stent you can almost treat like a pipeline device. You can kind of fluff it and add forward force to it so it herniates. So the neck, the bend in the stent will herniate into the aneurysm dome itself. And once the stent is in appropriate position, in your opinion, you can either proceed with coiling. In this case, Y stenting was thought to be the best option. So then you have a stent that was placed out the other P1, and you do the same thing, crossing. So you get this nice kind of support or basket to protect the basilar apex, the SCAs, and the P1s bilaterally. And then you can see contrast stasis just in the aneurysm dome, just from having the stents there. And then coiling almost seems like child's play, because technically none of these coils, if they're appropriately placed, should ever cross your Y stent. The hazards of Y stenting are the amount of metal you put in there. So we talked about right at the beginning of the lecture to have all of your anticoagulation or antithrombotic agents available and ready. And you want to make sure that is appropriate and ready, just in case the stent occludes, there's thrombus formation on the stent, and that's why even patients on dual antiplatelet agents can get in trouble. Moving back to the lecture. Those are just cartoons of different ways, and I've mentioned some of the ways already, but you can put a balloon, you can think of any creative way to place a balloon like you would a stent, and when it comes to dual catheter treatment or dualing catheter treatment, again, any configuration will work. Any configuration that you use with a balloon can be used with a stent, and you can use, nowadays, you can use the same catheter that you use the stent for as the balloon for. This is that paper that I mentioned. You can look it up as well, but you can use the stent catheter, the balloon catheter as also the stenting catheter. You get your balloon, you get your coils, you're not satisfied with the way it looks, and through the same catheter that is the balloon catheter, you can drop a stent just like you would any other stent, any catheter. This is a paper that I read recently, but just explains the craziness and how creative you can get with these kind of devices. This is not only is a dual catheter technique, this is also a balloon technique. And just to explain a little bit better, you have a big aneurysm. Normally you think, let's flow divert it, let's do something. Patient has a subarachnoid hemorrhage. Yes, it would be risky. Maybe you would do that with some coils. This set of team of individuals decided to have 2 microcatheters. They also decided to have a balloon and a Coiling catheter. The 2 microcatheters and a balloon catheter. They used the balloon catheter to protect this tiny blood vessel, which they called the anteroidal at the apex of the aneurysm. And so they protected the anteroidal by forming the balloon that was a hyper compliant balloon, coupled with the dual microcatheter technique with an excellent result, being able to preserve the anteroidal vessel, but also getting the aneurysm principally coiled. So, like I said, you can get really inventive with the microcatheter techniques in very difficult situations, and I would never say that I would never close any doors and be able to use the balloon to help you remodel the neck of an aneurysm. So always think of that as a useful adjunct. The addition of the dual microcatheter technique probably wasn't required, but does look like a neat way to treat this aneurysm. The other one thing that we have just briefly touched on today and yesterday was vessel takedown. A number of ways to take down the blood vessel, and is a useful option for when you're just like, I don't know what I want. I don't know how to help this patient, or something has gone wrong during endovascular procedure. I would harp on this all the time. When you're doing these treatments, always look at all the rest of the circulation. Don't just focus on where the aneurysm is. The balloon test occlusion test is very useful, especially in anterior circulation. A little bit difficult testing posterior circulation. I gave Zane, one of our fellows, a hard time yesterday about how you could test for posterior circulation balloon test occlusion. It's difficult, but possible. You want to make sure that you have looked at all the circulation. You want to make sure you have the appropriate balloon that can occlude, and you want to drop the blood pressure 15 to 20 points, and making sure that the exam has not changed after you do the balloon test occlusion. Sometimes electrophysiology can be used. I typically use transcranial Doppler. So you can use transcranial Doppler velocities. You can actually have someone with a transcranial Doppler in the angio suite, and you can look to make sure that the pulsatility index and the velocity stay symmetric when you do balloon test occlusion. I was trying to get Zane to, maybe talk about that yesterday when I was asked that question, that you could have used that for posterior circulation and make sure that the flow in the posterior circulation has not changed, because the exam is really difficult to tell if there's anything there. I think at one of the stations here, you had seen a device that can plug up blood vessels, but different types of coils can use to be plug up blood vessels. If you don't have a specific device, use large and long coils to do it. And onyx can be used in certain select cases to take the vessel down, but typically I've only seen it used when there's a disaster and there's a blood vessels that are torn open or has been transected in endovascularly, and you need to stop the bleeding immediately. I wanted to change gears a bit and talk about complications, how to deal with complications. So every case has worked out great, so far, and we don't talk about complications that often. But coils are coils. They're like any other device, can really get messed up. Stretch coils, migrated coils, prolapse coils, they kind of suggest the same thing. The coil is not where you want it. It either has kind of come out of the aneurysm dome, is sitting on the parent vessel. It is like, it doesn't look right, and you're just like, oh my God, I detached this vessel, I detached this aneurysm coil, and it's like floating around in space. I have no idea how to salvage the situation. We'll talk about intraoperative rupture, and we'll circle back to the beginning of the lecture with thromboembolic complications. There's a couple of techniques that you should keep always in the back of your pocket when you're doing coiling procedures. One is with the use of a snare, and the other one is the use of an alligator. The monorail snare method is very useful, and basically, let's say you have a microcatheter and it's attached to a coil at the end of it, and the coil is not in the right spot, and you may have not even detached it, but you have the microcatheter attached to a stretch coil or a coil that's not in the right spot. What do you do there? What do you do then? You basically snip the end of the microcatheter, So all you have is a microcatheter. Then you basically use this snare device, and if this is your microcatheter or the wire attached to it, you basically put the idea is to put this snare on the back table, or on the back of where the femoral artery or radial access, and then you pull that snare over the wire and then drive this whole system up into the head. And so once you drive the whole system up into the head, all you need to do is then cinch the snare down and then pull the whole system, including the microwire and coil, through your sheath, and it comes out in one piece. So most catheters that the snare works through are 21 or 21 thousandths of an inch, and I'll explain it again because it can be complicated. You have a microcatheter attached to a coil that is in the wrong place. You cut that microcatheter at the back of it. You have a snare or a loop or a hoop. You put that hoop across the back of it, and then you drive that snare device, including the hoop, up the microcatheter through your sheath and through your guide wire. And so at the top, you'll have, at the top, it'll look a little bit like this, or like this. So you can imagine it's attached to a coil up here. This is what it looks like inside the person. You cinch down on your snare, and then you drag this whole thing through. You'll drag both the proximal end back through, and the distal end is attached to the coil. So that's one way of doing it. Let's say the coil has been detached and it's just floating around. The other option is to use it. You can use the same snare method for that too if you want. But you can also use an alligator. Again, the technique is a little bit different. But it's very simple. You get to where you need to go. You unsheath this device around where you want to attach. You resheath it to connect, and then you advance the catheter that the snare comes with, and then once you've got the whatever it happens to be within the tip of the catheter that the snare is attached to, you pull the whole thing through. Very difficult devices to use all the time, and obviously stretch coils, detached coils, prolapse coils, these things don't happen all the time, but it's good to have both of these things available and ready in your angio suite, or at least have someone knows how to use them available in this case happens. The other option, which I didn't mention here, is hopefully you may have put this patient on dual antiplatelet agents. You can always just drop a stent to plaster that material against the wall of the blood vessel. That's one option. That's a third option, I guess, as well. This is one of the most terrifying complications. And basically, you're coiling or your catheter. You're impressing your boss. You got aneurysm. He's letting you get the aneurysm, access to the aneurysm. But whoops, the aneurysm catheter just popped through the dome of the aneurysm. What do? Do not freak out. Usually, you've perforated the aneurysm dome, and it's probably going to leak contrast, but not as bad as if you pull the catheter. For God's sake, don't pull the catheter back, because sometimes you've just release the dam, as it were, or release the plug. The microcatheter acts as a plug because you've popped through the back of it. Communicate at all times. You're the captain of the ship. If you freak out, the ship is going to go down. Everyone's going to run around as crazy as you are. So be clear. You're the captain of the ship in the IR. Talk to anesthesia right away. They probably will notice a spiking blood pressure when the aneurysm is ruptured. Talk to them about monitoring the blood pressure, making sure they have control of it. Talk to someone about bringing an EVD kit in the room. The EVD may save the patient. So while this is all happening, while you're thinking about solutions, communicate about that. Have coils brought into the room early. They may have already been in the room because you're coiling an aneurysm. Have the type of coils that you want to use right there and open in the back bench. It may be a waste of money. Have them open. Reverse the heparin, obviously, in case when you've heparinized the patient. If you had the patient on dual antiplatelets, DDAVP, and talk to your anesthesiology colleagues, have them transfuse platelets. Do not pull the microcatheter back. Keep getting x-rays. Keep the x-ray machine on. Keep getting runs until you're confident you know what the problem is, and then you can start coiling or doing something. While this is all happening, a third tech or someone else your assistant or even your boss can start prepping a balloon in case this is going to get worse and you need to put a balloon across the neck of the aneurysm. Most balloons are easy to prep. The high-perform balloon is the easiest to prep, and so sometimes it's the easiest to get up there and use. Keep coiling, making sure that at the end of the procedure, the contrast leak has gone away. Most of the time, if you're lucky, the hole is tiny, and for most patients, that leak closes itself on its own. But in case it doesn't, continue working with it, and in the worst case scenarios, you have to sacrifice the vessel or trap the area. Trapping the area is very difficult, but we talked about how to take down the vessel earlier. Making sure that you have distal access beyond the aneurysm is important. The other complication from hemorrhagic is thrombotic. Obviously, I had mentioned the use of heparin throughout the procedure. Here, we try to keep the ACT, or the activated clotting time, between 250 and 300 throughout the procedure, or twice baseline. If you decide to use either method, either you can make sure that it's twice the baseline or just a figure in your mind. Keep checking it every 20 minutes to make sure that the ACT is appropriate. It can be very easy to lose track of that throughout the procedure. If you're getting clot formation, repeat runs every few minutes to make sure that the clot is not propagating. If it's fresh clot, if it's fibrin, or if it's early platelet aggregation, there are things that you can do. ReoPro and Integralin are your friends in this case, and you can use them intraarterially or IV, the same biocompatibility. But since you might have a microcatheter right there next to the thrombus formation, you can just give it IA. The dosing I'd mentioned in the first part of the lecture, it can be up to 20 milligrams of Integralin or up to 8 milligrams of ReoPro that you give right away. And just keep checking the angiogram. If the clot is improving, put the patient on a drip. You can put the drip on for 18 to 24 hours. And then what we do here, since we have access to transcranial Doppler, is to check the transcranial Doppler postoperatively to check for vessel occlusion. And lastly, and I think you've seen one of these cases here already, you sometimes have to use mechanical thrombectomy if you have a distal occlusion, and judiciously use the equipment that you have in your IR suites to do this. Sorry about that if there's a whirlwind, and that was it. Any questions? Okay.